Thank you, Dr. Aborn. Thank all of you. We'll take questions, and we'll start with myself. In each case, we have 5 minutes. My questions actually are of Dr. Skinner. I'm trying to get 2 in here. One about this startling statistic about $700 billion in healthcare spending each year is wasted, which is about the size of the economic recovery package that we enacted, and it represents about a third of all health spending. And my understanding is when you talk about $700 billion, it's money spent on services that are not effective or that may even be harmful. But if you'd explain, where does this estimate come from? What do you mean by wasteful spending, and why is it so large?
Thank you. That's a great question. That is a big number. We had done some studies from Dartmouth that looked at outcomes of say, heart attack patients, hip fracture patients, a very large number across the country where we had very good detailed information on how sick they were when they arrived. Heart attack patients everybody's admitted to the hospital. You have some good information on how well they're doing. And what we observed in some areas spent 60% more on these patients, but they didn't do any better, and if anything, they did a little bit worse. And so we added up the number and came up with a number between 20 and 30% for the Medicare population. We extended that to the general population, the under 65 population, which, and also we also viewed this as sort of a lower bound in some way because probably even what we found to be the most effective, cost-effective areas could also probably improve a little bit as well.
So it's private as well as public. It's not all.
Yes, we don't have direct information on private, but we made inferences based on the Medicare population.
Now, what do you suggest we do to avoid this waste in passing health reform? I mean, I know you talk about the creation of ACOs, accountable care organizations, that would reward physicians and hospitals for effective management of cost and quality. How would that address the problem? Is that your answer?
Well, I think of ACOs in some way as very flexible, a very flexible approach that enables whatever kind of health reform that comes in to at least get at what we see that is the fundamental problem in healthcare, which is nobody's accountable in the system. That primary care physicians are overworked. They get patients. They send them to the ER. If they can't deal with them in their offices, they're 1 or 2 patients. There's a lot of fragmentation. All of these problems basically are allowed to grow and to cost us money and to result in bad care. And the ACOs are ways to try to stop it.
But how would they solve it? Because I don't want just another managed care organization. How are they going to help us?
Absolutely. I think the last thing we want is to live through the 1990s again with the problems of managed care. I think the improvement over managed care is that this is an example of providers, of these highly skilled physicians and other providers working together to try to basically sit down. Maybe this primary care physician that I mentioned earlier, who may not have admitting privileges at the hospital and sending their patients to the ER, they could actually get together with the people at the ER and figure out more effective ways, more ways to save money when they get difficult patients to come into their door.
But are you going to do it by changing the payment system, or, I mean, what's the mechanism? What's the enforcement mechanism?
Yeah, no, it's 2 things. One is you have to get the prices right. This is easy for me to say as an economist, but you also have to pay for the right things. Right now, we're paying per MRI. We're paying on the basis of quantities. And so basically, Medicare pays whatever people decide to do. What we need to do is pay on the basis of, is reward on the basis of total expenditures, that is prices and quantities.
There was an article, I'm going to ask unanimous consent to put this in the record. It's an article that's in today's New York Times about this study that finds that many on Medicare return to hospitals without objection, so ordered. But are you familiar with that? I mean, is that an example of how we could, of something that needs to be addressed, obviously, right?
Yes. I mean, right now, another example, that's a very good example. Another example was when a hospital figured out that when people came in with back pain, that if they sent them to see a nurse practitioner, rather than send them home and have them wait to go see the surgeon, then in fact, most of the back pain sufferers got better and went back to work. But the problem was that the hospital was losing so much revenue because it wasn't doing as much back surgery. And so they actually...
The bottom line is you're going to have to create some sort of financial incentive. I mean, this article talks about a financial incentive for hospitals that where they don't have such a return rate.
Yes.
And you would do the same thing with doctors and group practices and all that.
Exactly.
All right. Thank you. Mr. Deal? Oh, Dr. Burgess? Oh, you want to see it? Sure. Yeah, sure. Go ahead. It was in today's New York Times, and it's basically says that, there are a lot of hospitals where they have a high readmission rate under Medicare because they don't give people proper services when they leave, so they come back.
Right.
And one way of addressing it is to, create a financial disincentive for that to the hospitals. You're okay? All right. I didn't hear you. I'm sorry. So it's so ordered. Mr. Deal.
Thank you. Well, y'all have been interesting, and y'all have indicated the complexity of the issue that we face by the diversity of the subject matter that you've addressed, all of which was within that umbrella of health care reform, and I thank you for your testimony. But it's hard for us to get a handle on all of this, as I think you all understand. I think part of it is that we are trying to figure out objective standards to apply against subjective matters. For example, we have interfered with the private marketplace to the extent that in the private marketplace, a patient used to go to the doctor because they knew what his reputation was. You know, he was a better doctor than the other doctor who was in town, and so therefore they gravitated to him. Nowadays, there is, and this is the transparency issue in another format, nowadays, patients don't know what their Medicare doctor got paid. They get those billing forms. They can't decipher that. Even in the private insurance market, all they really know is what their copay was and what their deductible might be for the whole year. Nobody knows what providers are being paid for. They have no objective matter of judging the results. And what we're doing is we're saying we're going to transfer the ability to make those judgments to either the government through Medicare, Medicaid, and modifications of the reimbursement system based on results. Certainly, I think results ought to be good results is what we all ought to be looking for and trying to achieve. Now, in that regard, Mr. Smith, you referred to the fact the President says we're going to save every family $2,500 a year in their health care costs. How do we do that?
Mr. Deal, I think it means moving backwards from where we are, because I think what the approach thus far that I've been hearing about is actually going to increase costs rather than lower costs. But I think to start with that pledge of $2,500, which I think is that is what is getting the American families interested in health care, and I think they expect to deliver on that. I think we have to change the dynamics of our current entitlement programs. I think that we have to bring about the changes that left to the market will help lower those costs. As I said earlier, so many times we actually interfere in the market. One of the things, for example, is the tremendous growth in Medicaid and in SCHIP. We have actually taken healthy families and money out of the market. When we did that, we raised the cost for the people who were left in the market. This was the crowd-out effect that we talk so much about in SCHIP. So I think part of that is to return people back into the market rather than segmenting people off. The beneficiaries, I think, would benefit from that in terms of the continuity of care. I think we unnecessarily drive up costs When you get on Medicaid for the first time, for example, then a child is supposed to go for a checkup. No matter that he just had a checkup a month ago, we're going to insist that we actually drive up the cost of care. So I think that's a large part of it. And in Medicaid, I mean, we're talking about 45 million lives. To put that back into, to put those lives back in the market, I think would be at least a stabilizing effect on the market.
Let me ask Dr. Goodman, would you comment about the same thing? How do we save every family $2,500 a year?
Well, all of the proposals that I heard from the healthcare advisors to President Obama, all of the items they mentioned have been costed out by the Congressional Budget Office, and the CBO says there will not be savings in these programs. These are all, in my opinion, demand-side attempts to try to change how doctors practice medicine. And as I said in my testimony, I don't believe you can have great savings coming from the demand side of the market. We need to free the doctors and the hospitals. They know where the waste is. They know how efficiency improvements can be made, and we need to give them an incentive to do so. And that, I think what that means is empowering the secretary to allow every hospital to come to Medicare and have a different deal, have a different arrangement. On the readmissions, let the hospital have a warranty. And so Medicare doesn't pay for the readmission, but we have to pay more for the initial surgery. And we should be willing to do that because the warranty is worth something.
Are some of the stark anti-kickback provisions an impediment to doing exactly some of those things?
They are huge impediments. They may be doing some good, but they do a lot of harm. And so if we're going to renegotiate and let the providers come forward and say we want to be paid a different way, there has to be a way of getting around those stark restrictions.
Thank you.
That's essential.
Thank you. Gentlewoman from Florida, Ms. Castor.
Thank you, Mr. Chairman. Dr. Skinner, your data that shows the variations by region is astonishing, and I'm very sensitive to it coming from the state of Florida. South Florida is just infamous. So that we have high spending regions and low spending regions, and we can't really explain this by the difference in illness or prices. There's no guarantee that folks in South Florida are getting, much better quality of care. So I am particularly interested in your finding that the lower spending regions rely on primary care physicians to a greater extent. Can you give us a few examples of this, and why do you think primary care is more available, or is it more widespread in those regions? Is it simply that in those regions people need more, they have access to a better workforce? Could you lay that out in some detail for us?
Great question. I think understanding where physicians settle and where they decide to live and decide to practice is a fascinating but as yet and somewhat not well understood question, because there is a free market in where physicians go. But it seems to be that it seems to be that the approach of the primary care physician is to look at an individual and to think, there may be, for example, for chronically ill patients, there may be different organs which are failing, but let's think about how we can coordinate that care and think about treating that individual. Whereas I think sometimes the emphasis of a specialist is on that part of the body to which they're most highly trained to understand. And in many cases, you want to have a specialist on the job. But I think it can also lend to a large number of, in regions with lots of specialists, you can get many, many people treating the same, many different physicians treating the same patient. And there are these, what economists actually call network of externalities, in which I may be doing something as a physician which I think is best for my patient, but I don't know what all of the other physicians are doing as well. And sometimes the things I do may interact with what they do, resulting in not better outcomes. And so I think that's the best way I can think of to explain why in some areas, even within Florida, which is sort of a microcosm of these variations, you can find some regions where lots of people are being treated by multiple physicians, but they don't seem to be doing any better. And obviously, there's a balance. You need to have specialists in any system, but on the other hand, in some sense, you also want this idea of a medical home where somebody is coordinating all of that care.
And Dr. Cassell, I've met with a number of physicians, and they will share cases where a patient has come in and gotten a diagnosis and gotten tests, but they want a second opinion, so they go in to another physician, they get another set of tests, they go another place. Is there, there must be some answer to controlling, you know, if we're going to encourage a medical home, but you still want patients to have some flexibility, but there must be something we can do in cost structure and reimbursement structure. What do you recommend?
Well, thank you for that question. There is indeed, and the medical home concept and the accountable care organization actually are linked because they have to do with giving somebody the accountability to make sure that that coordination happens. So, for example, the patient with many complicated illnesses who's seeing 10 different specialists, and those specialists don't communicate with each other, could be taking medications that interact. They could be missing major things. You could end up in unnecessary hospitalizations and readmissions, et cetera. So, you know, you can actually make a patient sicker by too many doctors. Now, on the other side of the coin, the point that you point out, which is that the informed patient, it's a good thing that patients are asking for second opinions, in my opinion. I think that's what we want patients to do, to be asking of a surgeon, how many of these procedures have you done, and what's your complication rate, et cetera. And particularly in the diagnostic arena, to making sure that they get the right diagnosis. I believe physicians ought to be open to that, and they ought to welcome that. In a well-functioning system, though, you would have an electronic record, and you would have relationships with those specialists where you wouldn't need to do the same test over again just to get another doctor's opinion. You would share your records with the other doctor. And why should they have to order the same test all over again? Put the patient not only to the expense, but to the risk that every medical intervention entails. So I think you can create an accountability system around this. Part of the problem both of these notions are trying to solve is that 50% of the physicians in the United States don't practice in Geisinger or Mayo. They practice in single, solo practice or very small practices where they don't have that connectedness with their colleagues. We need to create some incentives for them to do that and to share records and to share the well-being of the patient around organizing that patient's care.
Thank you. Gentleman from Pennsylvania, Mr. Pitts.
Thank you, Mr. Chairman. Dr. Goodman, as you know, I'm sure many large employers are feeling the brunt of ever-rising healthcare costs, and many companies such as Safeway, among others, have created innovative ways to lower costs and improve health. Unfortunately, because many small employers fall under HIPAA requirements, they're not able to take advantage of this same opportunity. I'd like to know your thoughts on this. Should we change HIPAA to let small businesses take advantage of these opportunities? If so, you know, how would you change the law?
I think we should, and in particular, I think we need some pretty important changes in how we deal with the chronically ill, because that's where most of the money is spent. And we need to be able to, employers need to be able to make risk-adjusted deposits to the accounts of the chronically ill. So the diabetic patient, for example, can manage his own money, or the asthma patient can manage his money. A lot of care can be managed by patients in their homes. A lot of care can be self-managed, but if we're going to ask patients to manage their own care, they need to be managing the dollars. To make that possible, you need for the employer to be able to give different amounts of money to different employees, depending on their condition. And we also need a change in the health savings account rules so we can get rid of this idea of a deductible. We need to just carve out areas of care and say the patient's going to be responsible for certain things. We're going to put money in the account so he can do it. And the model for this, interestingly enough, comes from the Medicaid pilot program, Cash and Counsel, which is, I think, now in all 50 states. It's hugely popular. Patients like it, and haven't heard a single criticism of it. So, so that needs to be done, and we need clarification from Congress on what employers can do, the large ones as well as the small ones.
You also advocate making insurance portable. I believe. How would you, or how would allowing people to purchase insurance across state lines affect cost? Do you believe that the people can choose the plan that best fits their needs, or they need help? How would you change it?
Well, I do think we need a national market for health insurance. And of the two questions you asked, that's the easier one. Just let insurance sell across state lines the same way life insurance sells across state lines. The harder issue, and the far more important one, is how do we make health insurance portable? Because I think that's the next really big issue in healthcare. And in some ways, for employers, the sick patient is like a game of musical chairs, and it's intolerable for the employer. It's not good for the employee. So much better if employers could make a fixed dollar contribution to a plan that's owned by the employee, which he takes with him from job to job, that travels with him through the labor market. And we've proposed a way to do this for the state of Texas with Blue Cross of Texas. We think it's one way to do it nationwide. Probably I would let the states experiment with ways to convert the small business, small group market into a market for portable care. But that's really, really important. And I think portability is maybe the most important healthcare issue that you all are looking at.
How about risk pooling?
Well, the risk pool is there because we're failing on the portability side, and we're always going to need a risk pool if somebody falls through the cracks and for some reason doesn't have insurance and has health problems, and so that's a way to get health insurance to those people. But if you're in a system where you're insured and you stay insured and you take your insurance with you, then you will never need the risk pool. So the risk pool should be there, but they should be used infrequently.
Thank you. Mr. Smith, could you speak as to the issue of government plans competing along with private plans and your thoughts on that?
Yes, sir. I think it's an oxymoron. Government plan can't compete against the private plans because eventually there will be no private plans because the government plan will eat them all up. It is not a level playing field between government being a competitor in there where it can control benefits, it can control how much somebody is paying, et cetera. All of the advantages are on their side of it. They clearly would want to advantage itself, and it would create the rules to do so. So eventually, the private plans would not be able to compete. So we would end up later, if not sooner, under then a government plan, which I think would be a huge mistake. We've seen experiences of government plans. And I think that the private sector, and when there is real competition, and I had mentioned earlier, I think part of our problem is we keep interfering with the competition and say we don't want competition in many respects, whether it's specialty hospitals to where doctors can go out and form a group and provide a superior process. Government comes along and says, no, we don't want you to do that. Many respects, we don't want competition against our community hospitals. So we change the rules and bend the rules to advantage somebody else. So fundamentally, I think there's not a level playing field when a government plan is involved.
Thank you. I see my time's up.
Thank you. And now I turn to Mr. Sarbanes of Maryland, please, for your questions.
Thank you, Madam Chair. Thank you all for your testimony. There's two geriatricians, I think, at the table. I spent 18 years working with seniors in the healthcare arena, and so very focused on that. I also have a district that includes one of the most rapidly aging populations in the country in one portion of it. So on the question of the workforce, specifically today, if you were trying to encourage somebody to go into that line of work, what are 3 or 4 or 5 things that you would offer them, that you would change, that you think would incentivize them to pursue that kind of a career? Dr. Castle and Dr. Aborn.
Thank you, Congressman Sarbanes. Great question, and particularly at this time where all of these models of reform are based on the idea of not just better outcomes, but also more efficiency. You're going to have somebody who really understands that complexity of the science base and the evidence base and all the skills of working with the team that, as you know well, geriatric medicine involves. Right now, so the answer is, how do you create those incentives? I would say value, respect, and doability. And so value really is reimbursement. I mean, there is, geriatric medicine is now the only subspecialty I know of internal medicine. You know, we have internists who train and they become cardiologists and they become critical care specialists, and every time they get an additional training, they make more money. In geriatrics, after you do your internal medicine training, you get more training in geriatrics and you make less money than the internist makes. And so it's amazing anybody does it at all. But the few dedicated people who do it because they really find huge rewards in that, and it makes sense to them that the aging population needs this. So we have to find a way in the payment reform discussions to appropriately value that additional training and that additional skill. And I think there's lots of ways that we can do that, and I'd be happy to talk with you and the committee staff more about that. The second is respect, and you might find it odd that I put that in there, but I think Dr. Avorn can reinforce this, that within the medical profession, part of how you're respected is kind of by what the public thinks and what you're paid, and that value equals some combination of that. And if other specialists really believe that what you bring to the table adds value, then that adds a lot to the respect. Right now, it's such a small and in some ways embattled specialty that most specialists don't have any experience of working with a geriatrician. They don't know what that can value. The people who understand this now are aging baby boomers who've gone through this now with their parents, and if they can find a geriatrician, they say, oh my God, I didn't know they made doctors like that. So we somehow need to create systems, and accountable care organization might be one example of that, where there would be a defined role for that person, really taking advantage of their skills, taking care of the most difficult patients and the most challenging patients. So that's the second thing. And the third is doability, and this gets back to delivery redesign as well. Because right now in the fee-for-service system, in order to actually even just make the expenses of your practice and take home a reasonable salary to support a family, most geriatricians who are in private practice are doing things like Botox and laser skin surfacing, because what Medicare pays them for that complicated coordination of care, helping that patient and family find ways to stay out of the hospital, stay out of the nursing home, keep themselves as functional as they can with their Parkinson's disease and all of their conditions. Nobody pays them to do that.
Right.
So instead, they're wasting all that training doing Botox. So that's a real misuse, it seems to me. So I think it actually wouldn't be that hard to do within some of the things that I know the committee's considering within the payment reform.
Thank you. We just have a few seconds left, Dr. Aborn.
Yeah, sure. Just very briefly, my answers are exactly parallel to Dr. Castle's. It has a great deal to do with the reimbursement. Students come into medical school wanting to be primary care doctors, take care of the elderly, deal with chronic disease, and they come out of medical school looking for residencies in dermatology and plastic surgery. It is because they see their role models, and the people who are doing well and being rewarded by the system, both public and private, are the folks who are doing procedures. And the doctors who are simply taking care of chronically ill people are reimbursed in a manner that makes it virtually unaffordable to do that kind of work. So I think Medicare and Medicaid, as well as the private systems, could do a great deal in moving from a procedure-based reimbursement system, particularly invasive procedures, and toward a comprehensive care of the patient kind of system. And we've heard about that for a number of ways today. And then the last point is, it also would help if we had a healthcare delivery system that was structured so that the geriatrician, like the primary care doctor, didn't feel that he or she was out there waving in the breeze. If there was some integration of the system so that one was really part of a care network as opposed to somebody out there in left field, that would also make it a little bit easier to do what is probably the hardest job in medicine and the least paid, well paid.
Thank you. That's a great point. I know Congresswoman Capps and I are very focused on school-based health centers with respect to children, but there's also delivery models you can pursue with respect to seniors, community-based clinics, where do we reimburse, et cetera, that I think can advance the ball. So
Absolutely.
Thank you very much.
Thank you. Dr. Burgess for 5 minutes.
Thank you, and thank you all. Really, it's been a fascinating discussion this morning. I've got a number of questions I want to ask. If I interrupt you during your answer, it's not because I'm being rude, but I do have a lot of things I want to get through. First, Dr. Skinner, I want to talk just a little bit about the accountable health organizations. I spent a fascinating morning in December down at the Center for Health Transformation talking to four of the clinics that had participated in the physician group practice demonstration project. Were there talking about things that sound very similar to the accountable care organizations. In fact, one of the things that came up on the discussion was rehospitalizations and giving someone a doctor's appointment with their primary care physician within 5 days of their discharge from hospital for decompensated congestive heart failure resulted in an almost disappearance of the rehospitalization. So a very low cost activity with a very high yield on the other end. So clearly these are areas that that is incumbent upon us to explore. One of the things that came up was to get, how do we force doctors into these types of practice models? And I'm not a big one for forcing, so I put forth another idea, and I'd just like to get your thoughts on it. Medicare, of course, is a federal program. It's not a state program. It runs across the country. If we have groups that conform to all of the parameters set forth for accountable care organizations, and granted this will be flexible and this will change over time, but if we have groups that are willing to do that, the doctors within that group, could they, if they were offered protection from liability under the Federal Tort Claims Act, like we might do with a federally qualified health center, it seems to me that's a way to bring doctors into that type of practice. In fact, you might see accountable care organizations set up just to see Medicare patients so that they would be provided that cushion from liability. Do you think that is an idea worth exploring?
Absolutely. I think that's a win-win. I don't like to think about forcing doctors into ACOs, but I think there's also this that many physicians are concerned about SGR payment cuts, and that's another way to incentivize maybe making it worth physicians' while to start thinking seriously about whether there's a potential for an ACO in their area as well. But the more that these organizations grow up, spring up out of existing physician hospital networks, the better.
Yes, sir. Let me go on. And Dr. Castle, I wanted to ask you just a couple of questions. Actually, it relates to some testimony Dr. Skinner gave about the high cost of end-of-life care, the amount of money we spend within the last few weeks of a person's life with not really being certain that we're doing much to provide value. Now, Dr. Smith talked about how we sometimes do things and we make ourselves do things that aren't necessarily a good return on investment. When we did the Medicare Modernization Act, we required that everyone coming into Medicare now have an EKG on their Welcome to Medicare physical, even if they've had an EKG just a year or two before in conjunction with a surgical procedure. What if we were to offer, not require, but offer an educational module on advanced directives on that Welcome to Medicare physical? We could do it right after the EKG, in fact. The patient's there and put their clothes back on and could have this educational module. Sure, pay the doctor, pay the gerontologist for their expertise in providing this education. Maybe even incent the patient with some sort of break on the Part B premium or some other thing of value that we could return to them. But what do you think about exploring that as an opportunity for getting more people to thinking about planning for what happens at end-of-life care?
That's a very interesting idea, Congressman Burgess, and I think I'd like to consider it with you. I think that it's I can imagine the physicians not exactly liking that idea for most healthy, let's remember the Medicare age group between 65 and 85.
It's the new
those are
40.
very
Well, they're getting the Botox.
And, yeah, they're the ones there for the Botox, that's right. So they might be kind of put off by that, like, why are they making me look at this?
Again, not a requirement, but an
Right.
offer.
But an offer, there are very good models of shared decision-making, and again, the group at Dartmouth has been very involved in these and others as well, that show that when patients have all of the information and interact with their caregiver around that information, they almost always make more conservative choices about their care.
Well, I'm going to interrupt you, not because I'm not interested, but I have one last thing I want to get to, and I do want to work with you on that
It's
concept.
a good idea.
What about the concept? We had some other testimony earlier in the past couple of weeks regarding Alzheimer's disease, and if you look at the numbers, if people are correct in some of their projections, the numbers are just absolutely staggering from a public health cost. You talked about the gerontologists being out there kind of on their own, and sometimes it's a lonely existence. But with the interconnected world in which we live and we are constructing, would there be an opportunity for creating essentially a virtual center of excellence for the long-term management of the Alzheimer's patient, perhaps even considering some early diagnostics with things perhaps we can do with genomics, the monoclonal antibodies offering perhaps some real choices for early treatment. Is there a place in what we're looking at in the road ahead for developing this type of virtual center of excellence so that the practitioner's not kind of left out there by themselves on this?
So this would be a clinical center, not necessarily a basic research center.
Well, certainly you could have a physical basic research center, but a lot of practitioners who are in medium-sized communities may have a population of, say, Alzheimer's patients within their larger sphere of patients. If they could link in with other practitioners in, again, a virtual center of excellence, Alzheimer's patients are not likely to require surgery to improve their condition, but the medical management, the long-term management is really so critical.
Excuse me, Dr. Burgess.
And much of the reason is that geriatricians, as Mr. Sarbanes pointed out, are not widely available, so you don't even have that expertise. And many physicians don't know what to do. They don't pick up early symptoms of Alzheimer's disease. And, if they do, they're not sure what to do about it.
Right.
So, and they may prescribe medication unnecessarily, et cetera. So I think it's a wonderful idea. As you may know, I was part of the Alzheimer's study group with Newt Gingrich and Bob Carey and Justice O'Connor and others.
Dr. Castle.
And that was one of our recommendations, was that there be resources for community providers.
Great.
Thank you.
Let's work on this. Thank you.
Thank you. And I recognize myself now for 5 minutes. I will start with you, Dr. Aborn, because you speak a great deal about comparative effectiveness, and it's been a pretty hot topic around here. I'm particularly interested in your comments about translating information into better patient care decisions. And I wondered if you'd mind using my piece of legislation, a bill I've introduced, as an example. It's called and it's an acronym, Heart for Women Act. And among other things, it would require the FDA to collect and make available information about how drugs and devices work differently in patients of different sex, race, ethnicity, so forth. The goal being that a health professional could determine which drug might be most effective in their particular patient. Could you explain how this might be helpful for effective comparative effectiveness research, and why it's important that we have a data collection or information like this for quality of care and outcomes?
Sure. Right now, we have a perhaps efficient, perhaps skimpy approach to approving drugs, such that if it is better than, let's say, a dummy pill over a brief period of time in healthier people, then we know we'll take it. In achieving perhaps a lab test change instead of a clinical change, the drug gets approved. That leaves kind of in the dark patients who may be excluded from those trials. Often they are minorities, often they are women, often they are other vulnerable groups, and the very elderly, for example. And then the doctor, faced with trying to care for those people, does not have the information from their clinical trials that we would like to be able to really make a scientifically based decision for that patient, not the patients who are like the ones in the clinical trial. And so where comparative effectiveness research would help would be that it would make it possible to fund studies that would zero in on particular at-risk groups. Let's say a group of scientists, physicians, consumers would say, we don't really know enough about the management of, let's say, congestive heart failure in blacks, or atherosclerosis in women, or how Asians metabolize drugs differently. And we would identify, on the basis of the medical need for the information, studies that could be done.
May I interrupt you
Yes, please.
just because I want to move to another topic as well, but would you kind of locate such a place at FDA, or might it even be multidisciplinary in terms of
I
different?
think FDA's job is to approve new drugs, and
Right.
and we should have it.
Where would you locate this?
I would locate this in a trans NIH AHRQ setting that is a healthcare research, biomedical research entity that would then be able to make recommendations scientifically.
I hope we can follow up on this topic.
I'd be happy to.
Just opened it up, I know. I want now, with the rest of my time, to address you, Dr. Castle, because you spoke a great deal about the importance of coordinating care and the role of the entire clinical team in providing preventive care. That's a very important topic to me. But so many people talk about a medical home, which is in itself a fairly new phenomenon or label. I'd like to propose that we discuss it and talk about it as a health home. When we think of the word medical, we think of medical doctors and medicine and techniques. Rather, I believe we could be talking about the health of the patient as the sort of core, and all of the panoply of health professionals involved. And I wondered if you would sort of give a couple of ideas of how this might work, as I'm a nurse, and so I'm thinking of the different participants on this team and how that might be coordinated. But I also want to have you close by talking about the structure, how the reimbursement would work in such a model. I'm aware that in oncology, there's a whole team already, oncology nurses, who deliver much of the care, for which there really is no designation.
Thank you. And first of all, I completely agree with you. I think that the term medical home grew up in this model from pediatrics, which you're probably familiar with, which was where it first began. And it is, to my mind, unfortunate because, particularly from the perspective of a geriatrician, it's all about the team. And things like care coordination function, I don't think can actually be done by a solo physician or two physicians in an office with a medical assistant. I can't imagine how they could actually effectively do that unless they outsourced it or something like that. So to my mind, you actually need this larger team to qualify for being a medical home. Now, that's not in the Medicare demo legislation. There's a lot of reasons why you want to be able to have those small doctor practices.
I only have a few seconds. If we can demonstrate that this is important, it only will work if people get reimbursed.
How to do it is, I think there have to be some kind of bundled or global payments rather than because right now the Medicare pays the doctor. And you couldn't have Medicare pay every different health professional and still have that add all to everybody being accountable for working as a team. We know this from private industry. If you want to have people work as a team, you pay them as a team. And then you have the team figure out a lot about the reimbursement. So some mixed model that involves some degree of global payment would be my answer.
Thank you.
Madam Chairman, I'd like to defer to my colleague, Mr. Shadig, and then I'll take the next one. Thank you.
I thank the gentleman for deferring, and I thank the Madam Chairman. Dr. Goodman, I'd like to begin with you. You spent a lot of time in your prepared testimony discussing with how the system isn't working well for doctors, patients, employees, employers, people in the non-traditional workplace, insurers, the uninsured, and I tend to agree with you. And I want to kind of explore that. I want to explore, first of all, I assume the reason that it's not working very well is that the structure isn't suited to make it work very well for those people. Is that correct?
Yes, it's an institutionalized, bureaucratic system. Doesn't work like a normal marketplace, and therefore people don't have the opportunities to improve services and lower costs and raise quality the way they would do in, say, the market for other professional services.
Indeed, it certainly doesn't operate like a normal marketplace, because in this marketplace, the consumer of the good doesn't buy the good. That's kind of bizarre, isn't it? I mean, I'm the consumer of my health care. I'm the guy that goes and sees my doctor. I did over the Christmas break, went and saw a doctor, but I didn't hire that doctor, and I didn't hire the plan that hired that doctor. I just signed up to work here at the Congress. Is that a part of the distortion of this marketplace, and is there even a marketplace in health care?
Well, that's the fundamental cause of the distortion. As I said earlier in my testimony, it's also the fundamental cause of the distortion in the education market, which has many of these same problems. The entity that benefits is not the entity that pays the bill. If I can just add, there are emerging healthcare markets where third parties aren't involved: cosmetic surgery, LASIK surgery, the walk-in clinics, the concierge doctors. All of those areas are where the market's working well. You have price transparency, you have price and quality competition. So if we contrast those two markets, you can see radical differences.
I would argue the problem we have in the current healthcare market for most Americans is that it's all controlled by third parties. I'm a ploy, or one just kind of pawn being moved around, and my doctor is one also, and the whole thing's being controlled by my employer, who doesn't really care too much about, I mean, he'd like me or she'd like me to have a good health care, but that's about it. And then by the plan that my employer buys. I sent my staff an email a little while back where I said, okay, let's assume that going to work in Congressman Shadig's office meant that Congressman Shadig was going to provide you free lunch every day. And I posited that for one of my employees, I'd go buy him a ham sandwich every day, and for another one, I'd go buy them a salad. The problem is that the employee that I bought the ham sandwich for actually hates ham, and the employee for whom I bought the salad can't stand salads. That's kind of the way the so-called healthcare market works, isn't it?
Well, that's why I entitled those sections, free the doctor, free the patient, but also free the employer. He's not happy with this either.
He's not happy with it. We have a situation, I think the problem in healthcare in America today really comes down to two things. The uninsured, and I think we need to cover them all, every single one, and I've dropped a bill to do that, and cost, and costs are spinning out of control. I kind of drew this up. Here are the costs of inflation in our society, and here are the costs of health care or health insurance. Health insurance is rising exponentially faster, or health costs are rising exponentially faster than any other area, right?
Twice as fast as income growth. And by the way, it's not just a U.S. problem. That's happening all over the developed world.
Including other places where they've divorced the consumer from
everywhere, all over
the payer.
Yeah.
I just have a question for you. In auto insurance, I happen to note that I can't go home on one evening and watch TV and not see 2, 3, 4, 5 auto insurance commercials where the little gecko comes on and says he wants my business, or the State Farm guy comes on and says he wants my business. But I note that I never see a commercial like that from United Healthcare or any of the healthcare companies. Is that related to this problem?
Well, I do see some insurance commercials, but these are commercials for buying insurance in the individual market. They're not commercials for group insurance.
And what percentage of the American people get their health care in the individual market?
Oh, well, less than 10%.
And what's the government tax policy do to those people?
It discriminates against them. If you're self-employed, you get to deduct your premium, but you don't get relief from the payroll tax. And if you're just off on your own, you get virtually no tax relief.
You get smacked. You get smacked right in the face. You get told, well, you can buy health insurance, and we think you should, because we really don't want you to show up at the emergency room where you can get free care. But since we've told you we want you to go get health insurance, we're only going to charge you 1/3 more for it, roughly 1/3 more for it, because you've got to buy it with after-tax dollars, right?
Yes, the uninsured who happen into an emergency room more often than not get charged more than any other payer in the emergency room.
How well does a system of that type, of the type we have now, where you've divorced the payer from the consumer and you've put these people in between them, how much would that be helped by substituting the government for where the employer and the insurer or the plan is right now? Instead of having the plan, how much, by contrast, would it be helped if we made a direct connection between consumers and providers, hospitals or doctors, by allowing people to have the money they need to buy the plan that suited their needs?
Well, not very much help by the government, because in my opinion, the private insurance is almost as bad as government insurance. And half the people in the country are on a government plan. And
57%, I hear.
And the private plans pay the same way the government plans pay. So there's really not all that much difference. The markets where you really see a lot of difference are the emerging markets where there are no third-party payers at all, and those are working remarkably well.
Kind of like auto insurance, where people can buy directly from the auto insurer and get their car repaired?
Yeah, but I was thinking of markets where people pay directly for care.
Good enough for me. Thank you very much. My time's expired.
Mr. Shimkus? for 5 minutes, please.
Oh, thank you. Dr. Avorn, and I'm not sure who else talked, and I can get very deeply in this, but I am concerned about this cost effectiveness issue, and it was raised earlier. What's in a cost effectiveness ratio fighting aggressive cancer for 10 months or allowing the person to die because they have aggressive cancer in 2 weeks? If that was scored out budgetarily, what would cost more?
First, I think it's important to distinguish between collecting the information about what works and what is safe for patients and what is a good buy on the one hand, versus coverage decisions, which are really quite separate, so that one can imagine collecting the data about which treatments are the safest and the most effective versus their price. That's separate from what Medicare or Medicaid or a private insurer may choose.
Well, let me tell you why I mentioned this, and I don't, because I was, you know, I meet like everybody does. We meet with folks. We may have personal relationships of things that are going in everybody's life like this. I talked about my concern is a ration care system developing under cost. I was, again, at a student forum, and one of the students popped up and said, you know, well, it doesn't make sense to fight aggressive cancer for 10 months. The cost-benefit analysis doesn't score out. So for us to say that that's not part of a debate, which I think eventually we move to, if we don't keep private insurance as a very important option in this country, if we move to a public option which destroys the private insurance provision, and then we go to a one-payer system, that is my concern. A ration care system which will decide when you get care based upon budgetary aspects. And that's why those of us who are this comparative analysis, cost effectiveness, that's where our concern comes from, and I just wanted to throw that out to talk about that. And let's just kind of segue, and this will be, I think the chairman submitted this for the record, the New York Times article, is that correct? So my question is going to be related to the Medicare and really segue into Medicaid. One of the provisions that's being discussed here is Medicare for all. Okay, now if you believe this article, doctors are opting out of Medicare, and if you go around your congressional districts and talk to physicians, this is what we know is occurring. With this growing access to care issues, if we add millions of people to the Medicare system, a Medicare for all, does that help or hurt this problem of doctors fleeing? Anyone want to comment? Dr. Goodman.
It hurts it. What's happening now is Medicare is paying below market, let's say 30% below market, but not everybody can get below market. If you're a doctor, the first patients you want to see at the beginning of the day are the ones who pay market. And Medicare would be next, and Medicaid, which plays below Medicare, would be at the end of the line. If you try to put everybody into a system that's underpaying, then you exacerbate the supply side. And yes, it'll make the rationing problems worse. And rationing by waiting is not access to care.
Anyone else want to comment? Mr. Smith.
Sir, yes, and in my opening remarks, I did suggest that people look at the experience of Medicaid over the past several years, which resorts at the end of the day very much to price controls, to where you have access, real access problems for the Medicaid population. 1/3 of all Medicaid ambulatory visits are to an emergency room or to an outpatient hospital facility. So this is where a single-payer system ultimately drives you to, because you have now overburdened the system. As we have seen with states, then the reaction to that is to squeeze back against the providers to try to lower the cost that way.
I'm sure, did the Medicaid question get asked? Does anyone want to swap their current insurance policy for Medicaid? Did that get asked of the panel? Can we go through Dr. Skinner all the way down? Who would, let's start with Dr. Skinner, and I'll end with that question. Would any of you opt out to go to Medicaid over the insurance product that you currently have? You don't need to direct him, Dr. Castle. Let Dr. Skinner answer.
You needed help on that.
Well, I happen to have a pretty good plan, so I would not.
So you would not accept Medicaid as an
Not
alternative?
everybody is so fortunate.
I'm
Dr.
not
Castle?
sure why, what is the background of that question?
The question is the debate of if we have uninsured and we provide them access to Medicaid as an option, would you personally be willing to give up your current insurance product for a Medicaid? The question is that a good deal?
Well, the first
But
thing
the
is
real question I'm
very-
posing is, with the insurance that you
Right.
personally have, would you trade that if offered Medicaid in a trade?
No, if I were uninsured.
Okay, thank you.
You bet I would.
Dr. Goodman.
I don't think we're going to make it through the end of the line.
Well, I
just
think
with
we
the
will, if they'd answer the question.
Of course not, and I wouldn't trade it for
Thank
Medicare either.
But that's not the question. The question is-
I'm going to be distinctly different. I would. In my area.
We had one last week that said they would.
And Medicaid pays for all medications. You don't have to have anything out of pocket. So that I would actually. From a provider standpoint, though, Medicaid pays below the cost of providing the service. So it would be unsustainable.
You might have some access issues then with doctors not wanting to see
You would have some serious access problems, and it would be unsustainable to be in medical practice.
Mr. Smith?
No, in Medicaid, there are 56 different Medicaid programs, and in due respect to my colleague here, I mean, there are states that say you can have 4 prescriptions a month, so you don't have unlimited access to prescription drugs.
Dr. Avorn?
There are 47 million Americans who would say absolutely yes to that
No, the question is you.
Well, I happen to be an affluent American who has good
So
coverage.
your answer is?
I would not want Medicaid.
Thank you very much.
Well, now it's time to say thank you very much. The panelists have been amazing in your forbearance of all the questions, but also your testimony is valuable as we go about making some very important decisions in Congress affecting health care. Thank you very much.
Thank you.
We will excuse you and give you a break and ask for our second panel to take places at the table.
Not if they have a choice.
No,